A 65-year-old, 72 kilogram, 5'4" female is scheduled for an emergency exploratory laparotomy. Okay. Bleeding from dabigatran, bleeding from DIC, hemodilution, and I just put hypothermia there to be complete, but you got to be pretty cold to bleed from hypothermia. To have a valve area of less than 1.5, a diastolic pressure half-time of greater than 220 seconds. These are the patients that could be considered for percutaneous balloon valvotomy. Now that's a big step, right? But if you have too much volume, it can cause left atrial dilation, back up into the pulmonary circulation, and pulmonary edema. So hypotension going forward and pulmonary edema going backwards are the conflict. Do you need an FE1 FCC ratio? No, right? You get a history. I would know Pastigrel and Ticagrelor. I'd know dabigatran. I know rivaroxaban. I know apixaban. These are Bariplex, Cofact, Kcentra, Octopus. These are 4 factors, and some of them have protein S and C, and some of them don't. And this is probably the most famous diagram in monitoring for critical care. Why would the PAD not equal the mean PA pressure? Why would the pressure here not equal the pressure here? I mean, it's just a few millimeters. What is right there obstructing flow? Pulmonary hypertension. And so now the mixed venous O2 sat becomes a balance between the supply and demand of the body. On the supply side, you have saturation, cardiac output, hemoglobin. On the demand side, you have demand. How do we understand this thing? Okay, first of all, no one really understands it well, but you will after this. What is the change in your blood pressure if you're dry with a positive pressure breath? Your negative intrathoracic pressure will suck blood up from the head and suck blood up from the body, right? And if the IVC diameter collapses with that inspiration, collapses too much, we call that the caval or collapsibility index. Right. But if you're down to room air and you had a PF ratio of 200, that means your PaO2 is going to be 40. Imagine that. You have venous blood floating around in your arterial circulation. Once you have an acute hemolytic transient reaction, you have antibodies stuck to the transfused red cells. Then you could take the patient's blood, their whole blood, and add antibodies to antibodies, antibodies to antibodies that clump red cells in the patient's blood, means the patient already had antibodies attached to the red cells. So a direct Coombs, the recipient's blood. So I would not extubate until all those problems were resolved. And it is the hardest thing on the boards and sometimes in practice to keep track of the multitude of problems. But as a consultant, that's your job, to look at the big picture and take care of small picture issues at the same time. Big and small is your job.